Today we have with us Dr. Narasimhan Swaminathan. He is a physiotherapy educator and researcher working as a professor of physiotherapy and vice principal, faculty of Allied Health Sciences, Sri Ramchandra Institute of Higher Education and Research, Chennai, India. He has completed his post-graduation in cardiopulmonary physiotherapy in 2003, and also he has done FAMER fellowship at ESG Regional Institute in the year 2012. Before Chennai, he was working at Father Muller Medical College, Mangalore, and there he worked as a vice dean also. He has completed 3 funded educational research projects, and currently he is pursuing his PhD in health professional education. He is a member of Sri Ramchandra Center for Health Professionals Education and involved in training the educators in blended learning. He is a consultant for PG curriculum development at Sri Lanka, and he is also a visiting professor at Bournemouth University, UK, and adjunct researcher to University of South Australia. It is a pleasure to have you, sir, with us, and I hope our students will have a great knowledge from your side. Over to you, sir.
Good morning, all. Thanks, Dr. DT, for your wonderful introduction. I'll start sharing my screen now. Yeah. I hope the screen is visible now.
Yes, sir, it is visible.
So, once again, good morning all. Welcome to this session on critical care physiotherapy and evidence-based approach. I thought we should discuss about the evidence also. So I am trained in critical care since 2000 words. So this is one of my core area of interest and research. So what I will be sharing today with you all, our practical experience underpinned with evidence in critical care physiotherapy. So the objective of this session are 3. So at the end of this session, the participants will be able to understand the importance of critical care physiotherapy. You're going to reflect on the current practice, what is happening here, and you will be able to appreciate evidence. So I'd like to declare that some of these slides are presented elsewhere for the teaching purpose. So I'll be using the same slides of mine for this presentation also. So the point here, which is important, I want you to reflect on the current practice. When we think of critical care physiotherapy, so what is the current status? As a student, if you get to observe what is happening in the critical care, and if you get to practice, you need to see what is happening now and what is the evidence and where we can take this role of our physiotherapy in critical care to the next level. So I just want you to reflect, as I told you. You have a patient, he's 44 years old male. It's a known case of COPD. You know what is COPD? Chronic obstructive pulmonary disease. So he has been admitted in the critical care unit following acute exacerbation. The patient is tachypneic. The patient is on NIPP, non-invasive positive pressure ventilation. His ABG report shows severe respiratory acidosis. So now I want you to reflect and answer. Do you think physiotherapy is indicated here? Do you think physiotherapy is indicated? Probably you can put it in the chat box. Dr. Diti, if you could share the responses.
Yes, sir.
Do you all think physiotherapy is indicated now?
Sir, according to few students, yes. According to few, it's no.
Those who said no, and those who said yes, can you give us the reason? Why do you say yes? Why do you say no? Can you tell us the reason? Tell me the reason. Why do you say yes? Why do you say no?
So actually, they can respond only on FB. The few who are on Google Meet, they cannot respond.
Okay, so you'll not be able to see the answer.
Yes, sir.
Okay, that's fine. So please reflect. If you say yes and if you say no also, we need to have the reason. When I say yes, why I am giving physiotherapy, why physiotherapy is indicated, what is my role, what I'm going to do, for these patients, whether physiotherapy is going to be helpful physiologically. There's another one of the X-rays. If you could see that, there's a chest X-ray of a 63 years old man. He had a history of ischemic heart disease, and he has been a heavy cigarette smoker. So this is the X-ray taken on the first post-operative day. So I think physiotherapy is indicated. If indicated, yes, what can be offered? If no, why physio is not indicated? First thing is that your clinical decision making, the reasoning is important. It is not that all the patients require physio. It is not that all the patients will get the same type of physiotherapy. Physiotherapy is in critical care. It is not that one size fits all. Hope you understand that. Every patient is different. Every patient, the indication is different. Okay. So now, what is the role of physiotherapy? All my presentation is based on this particular review we have published recently. Uh, you can download this, which is freely available. So we put all the current evidences and we reviewed. So the entire presentation is based on this review. So we'll be focusing more on that. So physiotherapy in the critical care from the beginning, it is to, the indication is if there is retention of secretions, and if you see there is impaired gaseous exchange or respiratory muscle weakness, that's from the pulmonary side. That's from the pulmonary side. So the retention of secretions is the one thing from the beginning when the physiotherapy started in critical care. That is the focus. Even today, that is what we are focusing in our country. We should look beyond this also. So what is the pathophysiology of secretion retention? If you see, there are various parameters. First thing is immobility and altered physical mechanism. The upper respiratory tract is bypassed, especially if the patient is intubated. And there may be underlying disease process, like they have COPD, or they had undergone major surgeries. That underlying disease process itself is one of the reason for retention of secretions. As I told you, the presence of artificial airway and impaired airway clearance, all these things lead to retention of secretions. So what it will do if the secretions are retained? The retention of secretions obstructs the airway. That will lead to ventilation perfusion mismatch, and that will lead to hypoxemia. You should know the difference between hypoxemia and hypoxia here. Hypoxemia leads to hypoxia. The tissue oxygen supply will be affected. The reason is retention of secretions. So retention of secretion, that leads to ventilation perfusion mismatch, that leads to hypoxemia. So what physiotherapy can do? If you all think the traditional one, uh, you know, percussion, vibration, go into postural drainage. But what is it? The first thing is positioning. We in the ICU, we adopt 5 different positions, but every position has its own physiological effect. We need to understand that. By understanding the physiological effect, we will be able to select the ideal position for right patient. So positioning is the first thing you need to consider when you're working in the critical care. So what this upright position does, the upright position improves lung volumes and it decreases the work of breathing. We should keep this in mind. On my assessment, if I find the patient's lung volume has to be improved or the patient has increased work of breathing, especially immediately after extubation, we need to understand upright positioning may be useful. So that is what we need to pick up this position. So if your objective is to improve the lung volume or to decrease the work of breathing, we need to go for upright positioning. What is lateral position, Jeff? You know that right lateral or left lateral. So this lateral position improves the VVQ match. It enhances the airway clearance. So when I identify the patient has impaired VBQ match, unilateral lung disease, the ideal position which we should consider is lateral positioning. We should also use it for airway clearance. So prone position, we know that it is proven that prone position improves VBQ, especially with ARDS. The prone position increases VBQ matching. It redistributes the edema. It also increases functional residual capacity. So if you identify any of these as your problem, you should consider prone line. Head down tilt is mainly used for airway clearance. Of course, we should be very cautious while going for head down tilt. But in ICU, if your assessment is clear, it is very safe to go for head down tilt unless until patient has any head injury, trauma, or any recent surgery. So head down tilt, if you're not going for head down tilt, airway clearance from the lower zones may be difficult. So head down tilt. These are all the 5 positions. And then the gold standard till today, what we consider in our ICUs is post-postal drainage. We use 11 positions to drain 14 different segments. So what it does, postal drainage, we know that it enhances the peripheral airway clearance, it increases the functional residual capacity, it also so it is considered as a gold standard, but as per the evidence, not a gold standard because poor practice of techniques. When we looked into the practice of postal drainage, the practice is poor, across it is not standardized. There is minimal documented evidence. So we should not consider postal drainage as a gold standard in the critical care. We do have other techniques until it is warranted your assessment. That's what the evidence says. Because the practice technique is very poor, we don't have any documented evidence. But positioning, yes, you should consider. There are other techniques for airway clearance. I'm not telling you should go away with postal drainage. Postal drainage should be used whenever necessary. Then gestual manipulations. Again, it is used, percussion, vibration, rib shaking and springing, all these manipulation techniques. But the thing is here, there is no uniform practice here. There is no documented evidence for this also. Not much in used in developed countries. This is one of the paper. This was published in 2014. So since there is no solid evidence, we should really look into that. Why we should practice percussion, vibration, rib shaking, and springing. The next technique we should consider is manual hyperinflation. So what it is here, we are providing the larger tidal volume than the normal expected. So we give more than 150% of the ventilator volume, or you can use manual rebreathing. Bag size is more than 2 liters. The flow is 15 liters per minute. That was the one it was recommended. So how the manual hyperinflation has to be done. So what we do here, there is a slow deep inspiration followed by an inspiratory hold and then a quick release. So you have a slow deep inspiration and then there is an inspiratory hold and then quick release. So that enhances the airway clearance. So this is what used Maplin C circuit. If you see, this is a bag and this is connected with the oxygen supply. You get 100% oxygen from the oxygen supply. And this is the valve. Here you can adjust the pressure. So you administer the higher tidal volume to this and then sudden release. So that enhances the airway clearance. So yes, it has mixed evidence, but it seems to be safe if we consider all the parameters based on the guidelines. So that's the paper which gives you a detail about manual hyperinflation, how effectively manual hyperinflation could be used. So consider manual hyperinflation if your patient has retention of secretions. But one thing, you should be trained and you should be kind of a certified to use these techniques in the ICUs. Coming back to the next technique, the inspiratory muscle training, it seems to be effective, especially when the patients are in the ventilator for a longer time, if you are finding it difficult to breathe. So the inspiratory muscle training seems to be effective. So inspiratory muscle training using, you could see some of the picture, the tracheostomy patient, what we used in our setup earlier. You could see that inspiratory muscle training, we also documented. It is helping. There are very many tools are available. You can, if you're trained, you can try inspiratory muscle training. So that's one of our study we published, and we looked into the inspiratory muscle training in improving respiratory muscle functions in patients who have undergone coronary artery bypass graft. That's one of the earliest study what we did. We also tried using inspiratory muscle training in weaning, but that was a case report and we couldn't do a randomized control trial. So in this study, we could see that those who are trained with inspiratory muscle training, their recovery is better. So in the critical care, one of the area we should consider using this inspiratory muscle training. The important part of the critical care physiotherapy is we need to understand apart from this airway clearance and everything, we need to understand the bed rest is not benign. People, those who are admitted in the critical care unit, they are totally immobilized, and the security of immobilization is very important, where physios can help in reducing the immobilization complications. If you see the key role of physiotherapy now, it's more the paradigm shift. It is early mobilization. So why we need to mobilize early? What happens when the patients are immobilized? The first thing, there is aerobic deconditioning. That. When they are immobilized, there is a first thing, there is aerobic deconditioning. And neuromuscular inactivity happens. So because of that, again, the skeletal muscles goes for proteolysis. So the weakness, there is a weakness in the anti-gravity muscles and all the skeletal muscles. Even the respiratory muscles goes for weakness. We have enough of evidence to say, documented evidence, immobilization increases the respiratory muscle weakness. And there is fluid volume redistribution because of immobilization and a prolonged supine line. It also leads to psychosomatic abnormalities. That was documented in 2002. If we all know that Dr. Elizabeth Dean, you notice that. So, what leads to the deconditioning? What happens? The deconditioning because there is a functional denervation of the muscle, and there is going to be accelerated broncholysis of the skeletal muscles. Then there is going to be this leads to deconditioning. So, as a physio, we need to understand that. We need to understand that's very, important point for physios to consider. So, that means when we should mobilize, we will be able to mobilize the patients only when they are conscious and they should be alert, they should be oriented. That's the first thing. When we say that, this gives you a clue what are all the things we need to assess. Because we need to see the link. We need to see the link between everything. So we need to see the patient is whether the patient is conscious. So the tool to assess the conscious level, whether the patient is alert and oriented. You should document that in your assessment. Next step is looking into the hemodynamics. They should have stable hemodynamics. Once you are clear with the hemodynamics part, there is no heart rate change or BP change. Once you noticed all those things, and then you can go to the next system assessment. That's what assessing the whole system is important for us to take a decision whether to mobilize the patient or not. Then we need to look at the musculoskeletal system, neuromuscular system, and surgical notes. You will not be able to mobilize if the patient has any problem with the musculoskeletal system or acute impairment in any of this system. So we should be very careful. Once you assess, then you can think of mobilizing. So what are the benefits of mobilization? Acute physiological effects of mobilization. What is documented is in respiratory system, early mobilization or mobilization improves the respiratory mechanics. When we say respiratory mechanics, it improves the what we call lung compliance, the functional residual capacity, the function of the respiratory muscles, and it also improves the gaseous exchange. It also improves the gaseous exchange. When we look into the circulatory system, what it does, it improves the cardiac output. It enhances the peripheral oxygen extraction also. Nervous system, if you see early mobilization, improves the arousal level. It also improves the mental function. It also improves the mental function. So, positive effect of mobilization. This has to be translated. If you see the entire team, we are the movement expert in the ICU. So considering the positive effect, not only that, it also releases the catecholamine distribution and the degradation. It also, the gamma patient, it is becoming better. The renal system functioning better. It also improves that mobility. Then the cutaneous circulation also. If you see, almost all the systems positively, affected by mobilization. So that is what there should be a paradigm shift in critical care physiotherapy management, especially when you consider the benefits of early mobilization. you know so plenty of evidence. This is the particular issue of critical care clinics. It's one of the reputed journal for critical care. If you read this particular issue, this whole issue is dedicated for early mobilization. See, this happened in 2007. Now we are in 2020, 13 years. After that, we have pile of evidence. You could see these are all some of the interesting papers. It said the safety issues, the protocol which we developed. It's the safety issue based on these kind of the papers which was earlier published. Transforming ICU culture to facilitate early mobility. That's another paper. I want all of you to go and look into this issue, and you will understand how important early mobility is. This is what proposed by Kathy Stiller at the beginning. She proposed algorithm, a flow chart, how you will be able to mobilize the patients early by following a protocol, step by step. The first step, you are reviewing the medical background. That includes the medical history and the medication, what they are using, and their previous level of mobility, very clearly, step by step. Once you are clear with that, if you see that medically the patients are stable and they will be able to mobilize, and then you go and assess the cardiovascular wisdom. You see, that's what the physiotherapy assessment is very important. Reasoning, by assessing everything, and how are you reasoning it out. The resting heart rate should be less than 50% of age predicted. What is age? 220 minus age? That's what the recommended one. The blood pressure should be less than 20%. Variability recently. That is what you are reading the case sheet. You are looking into the document. The blood pressure variability should be less than 20%. ECG should be normal. There should not be any evidence of myocardial infarction or arrhythmia. Other major cardiac conditions has to be excluded. You will understand why your assessment is important, why you need to look into the documents, why you need to interact with the team, those who are in the ICU. So if it is no, defer the mobilization. If yes, go to the next step. She rightly projected Stiller. If you are unsure, discuss with your senior physiotherapist. And then you go to the respiratory reserve. All the points, the ratio between PaO2 and FiO2 is important. It should be more than 300, and SpO2 should be more than 90%, and less than 4% decrease and decrease. Again, recent decrease means you are looking into the document and you are seeing whether the change happens recently. Then you should observe the respiratory pattern. Though the patient is ventilated or not ventilated, you need to follow that. Even you could mobilize the patient with mechanical ventilator also. We'll see later when we progress, how we could mobilize patients with mechanical ventilation. That's what they should be able to maintain, during the treatment. If yes, go to the next level. You see, she rightly said it is not only with the respiratory, you see all other parameters. The blood levels, the hemoglobin levels, the platelet levels, you see all the parameters. See, that is what, again, I would like to stress that, when you're working in the ICUs, your assessment, your document reading is very important. You need to interpret, you need to reason out. If everything, and then go for mobilization. So what we did based on this, because this is very, very well structured, and this gives more scope. So we modified the protocol. That's Kathy Stiller. I should thank her, for such a thing. This is what when I visited her in Agilite, she was so nice and she explained everything and all those things. I should give the credit to her. So what we did, based on that, we modified the protocol for our setup sometime back. What we did, first, step one, review the medical background. There is no change in that. That's what we followed. We adopted some of the things. The ECG is must. Step 3, if it is no, we will not go for mobilization. If it is yes, go to the respiratory zone. Okay. So respiratory pattern, if they are able to maintain the mechanical ventilation. Here the parameter is changed. You should be able to fit into your setup, which setup you are working for. You should look for that. Sometimes we accept 200. If it is yes, go to the next. All other factors, what is mentioned in the evidence. We should look for all other factors. whatever the blood investigations and the hemoglobin level, everything has to be important. And then if you say yes, go for mobilization. This is the protocol again based on some of the evidence we adopted for our protocol. So it is not just directly making the patient up and run or something. First sitting with support. Phase one. To go phase one. Sitting with support. Do exercises up to the tolerable level. Then phase two. The patient is comfortable. There is no change in the vital parameter. The patient is able to tolerate that. Then go to the phase two, standing with support and supported spot march. First standing with support and then supported spot march. You see the stepwise. These are all published in the evidence we adopted. Then phase three, standing without support, spot march. You see the phase two, standing with support, supported spot march. So the patient is stable, the vitals are stable, and then go to the second step, standing without support and spot march. So you are slowly encouraging the patient towards independence. But each and every step, the monitor has to be noted down. We should ensure that there is no change in the parameters, vitals, acceptable. It should be acceptable. You should be able to, see that there is no abrupt change. You should be very careful. So every step we need to monitor. Then phase four, walking with minimal support. They are slowly progressing. So that is how you see some of the pictures, what we used to do in our earlier ICU where I was working. And for the Millers, you see the phase one mobilization. You will see that, the patient is sitting, the patient is mechanically ventilated. The therapist makes the patient sit with support and the monitors are observed and you can see the patient is sitting, fully. Phase one, you can see that with support sitting. You can see the patient is getting ready for standing now. So these pictures taken some year back. You can see the therapist is instructing. So what is going to happen to the patient? You can see the patient is ready to be ambulated. Phase two, supported stand and supported spot march. We could follow this protocol very safely, because of the team is trained and we had a very good inter professional collaborations. We could be able to do that in our ICUs. Phase three, you can see the patient started walking with the ventilator support. The spot march and within the. So there are some of the tools you should understand. I would like to introduce these tools. It's called physical functional ICU test, PFIT. So this is, by using this tool, you'll be able to document the patient mobilization and you'll be able to prescribe the patient's mobilization. Okay, so it's a simple tool. You will see marching on spot, yes or no, how many steps they took, stop if more than 2 seconds elapsed without a few steps. So you are scoring 1, 2, 0, 1, 2. Right and left, and then finally we'll arrive to a score. It's a simple tool. So what we did, we tested our protocol, though it was a small study. It's also published. So we tested our protocol, randomized control trial. So we had two group of subjects. So one group, we had early mobilization. The other group, the routine physio, because early mobilization was to introduce as a must protocol. So we tried the randomized control trial. Though the sample size was less, we could see the number of days out of bed was significantly less in the early mobilization group. Of course, we are mobilizing them. You see that the maximum was 4 days, whereas in control group the maximum was 7 days. The minimum was 7 to 9 and 2 to 4. You could see that. So that is what we need when you mobilize the patient early. They can get shift out of the ICUs at the early. So that is what we could prove that with the protocol what we used. Again, the number of days of weaning, you see that again, the minimum was 5, the maximum was 6, whereas in the other group, control group, it was 7 to 9. Of course, the study had some of the limitations because the heterogeneity of the sample, what we include, and the pathophysiology of the sample, what we include. But we could prove that early mobilization is effective. Physio-led early mobilization. It was led by the physio. Of course, we worked as an interdisciplinary team, and it was led by the physio. So it is effective. That's what we want to say. Is there any contraindications for physiotherapy in ICU? Means we need to look into the benefits and the risk. If you see the benefits more and the risk less, you should go ahead with that. Okay, and if the risk is more, no physio. That is what you need to buy. Your assessment and clinical reasoning is very important. Like elsewhere. Wherever you are working, but in critical care, you should be very sharp. Our decision making should be sharp. So there are plenty of evidence. If you look into that, we are a member of critical care team. That's a position statement. European Society of Intensive Care Medicine. You see, physiotherapy is mandatory. So enough of evidence. From 2006, Linda and so many, they are doing a lots of work. Work in ICUs. We also looked into what is the, you may be interested in, a kind of what we can do in the COVID situation. So one of the statement which has came out from Italian group earlier, and they suggested reduce unnecessary maneuvers, especially when the patient is in the ICU. Similar way it goes what we discussed. And again, they were telling all these procedures has to be reduced, but they also suggested, recommended, you should also look for early mobilization. We worked as a team. We came out with a national guidelines for us for acute care COVID management. Probably you could refer that it is there in Indian Journal of Critical Care Medicine as an online first paper. It published in the last week. So we documented, we identified a consensus from therapists practicing in the COVID ICU, and then we identified an algorithm also. If you're interested, you can look into that. So that is what that document says. So to summarize, when you look into the physiotherapy practice in ICU, your knowledge and skills are very important. You need to have a sound reasoning skills, and you need to consider the virtues of the things, and then the movement is important, as I was discussing. As recommended by Jensen, these are all the core dimensions of physiotherapy practice. All these things are applicable in critical care also. We need to understand that we are the movement expert. Though there are many people in the ICU team, physiotherapists are the movement expert. We need to focus more on early mobilization. So the key to success in any practice, especially in critical care, you should have adequate knowledge and skills. If you see the protocol, what I was explaining, it requires more amount of beta cognitive skills and your reasoning skills. So don't just think that every patient will be treated as the same in the ICU. That is not the case. Every patient is individual, and for every patient, your protocol is different. Your assessment is different. Your clinical decision-making skills should be strong enough. You should also develop interprofessional relationship, because it's a teamwork. It's a teamwork. Every member of the team is contributing, and you should understand the other members' role also. We should be practicing using the evidence, and there should be more awareness about this has to be created. So, any questions? So we'll keep next 10 minutes for discussion. Any questions?
Sir, one question is there.
Yeah, please.
What can be the possible complications of giving physiotherapy in ICU?
Yeah, possible complications, it depends upon what you are doing, See, the thing is, that's what as I told, you need to assess whether physio is required. Possible complications, documented evidence, there are rib fractures following percussion, that is documented. So it depends what you are doing, For example, while positioning, if you are not taking care of the lines and tubes, that could get dislodged. So you need to be very careful with lines and tubes also. So one thing in the ICUs, you will be able to see the hemodynamic changes during the procedure in the monitor. So that itself you will be able to identify what is there any changes happening.
Okay, sir. One more question is there. How to improve our clinical decision making?
Yeah, that's a nice question. So your clinical decision making, you require more metacognitive skills for that. The case discussions, how many case discussions are happening? That is what if you see. First, you need to observe what your senior therapists are doing. Once you observe, you should discuss different cases, different scenarios. To go to that level, your basic knowledge is very important. The physiological knowledge, where it works. When you interpret a ABG report, when the oxygen level is less, what are the possible reasons for oxygen level is less? What are the possible reasons the carbon dioxide level is high? Why this is getting altered. Then that should be applied with the clinical situation of the patient. So you will be able to develop that when you discuss more cases, when you participate in discussions with your senior physiotherapist during the bedside teaching. It will develop when you become more expert.
Okay, sir. Sir, these are the only questions we are having as of now.
Oh, I was thinking there's going to be more discussion. That's what I kept it last 10 minutes for discussions.
Yes, sir. Okay, one more question. Somebody is asking, do we need to train ourselves differently to work in ICU, or only bachelor's in physiotherapy will be enough?
Yes, you need a special training because ICU is a specialized care. That's what as we were discussing, your reasoning skills and how you are managing. You definitely require a special training. But what I understand, our entry-level graduate physiotherapy curriculum provides you opportunity to understand the fundamentals of ICU care. So if you want to specialize yourself, yes, you need a special training. There is no doubt in that. Because the environment is different, the practice pattern is different in critical care.
Okay, sir. Okay, sir, I guess we don't have any more questions. Then we can end this session here, sir. It was a very informative and very nice session. We really came to know a lot of things which we didn't know before, and we also understood how much evidence-based practice is important and how to incorporate that into our daily practice. Okay, sir, one more question. Sorry.
Yes, please.
Yeah, working continuously for early mobilization is important, but what are the signs that we see that shows the therapy might fatigue the patient, or it is going above the requirements.
Yeah, all the vital parameters, heart rate, BP, saturation, and facial expression of the patient. The patient is intubated, or the patient's compliance. You use both scale the patient can express. That is what the tools what we document. That's what the documentation becomes important there.
Okay, so that is what we are supposed to observe during giving the therapy also, like continuous observation. Those are the points which we will see.
Absolutely, we should not overdo. We should be very doubly careful when we are working in the ICU.
Okay. One more question. Do we need to consult a doctor before giving a upright or a standing position to the patient?
See, again, as I told, it's a teamwork. If you are there in the team, you understand that that's indicated. I don't think every time you need to get their approval for positioning and all. But in every day's discussion, the plan for the patient care is decided as a team. It's a teamwork. So you decide what is required from your side for the patient. I understand what you mean. It is the professional autonomy comes in there. Once you are working in the team, your autonomy is valued there, and you decide what to do for your patient. If you are changing the protocol, definitely it is not only the consultant, the entire team should be aware of. Similar way from the other side also, when they change any protocol, when you are working as a team, you should be also informed. You will be informed that what is happening and why the protocol is getting changed.
Okay, sir.
Working in ICU it's a teamwork. It is not one man show. It is a teamwork. Even when we mobilize, we need other people to be around you. We need to have the nurses with you, and we need to have the people those who are involved in the care. You need to be with you when you are mobilizing the patient. It's a team care.
Sir, one more question. How to, if what happens if we are giving a treatment and there is any kind of emergency, then what we are supposed to do? How we are supposed to handle it?
Yeah, that's what somebody asked, whether I should be trained when I'm working in ICU. Yes, those who are working in the ICUs will have ACLS certificate. In that kind of emergency, you need to call the team immediately. You will be trained. You will be trained what has to be done. The team is available. You need to call the team immediately. The nurse will be there readily, because the ratio is 1:1. Every patient will have a nurse. That is what the interdisciplinary work comes. You are responsible for the patient, and you will be calling the team, and the team will help you. He will be there during the emergency. You will be also trained in the emergency situations. You will be trained in ACLS if you are working in the ICUs.
Okay, sir. Sir, I think we are done. We don't have any more questions coming up also.
Okay, thank you very much.
Thank you, sir. Thank you. It was a pleasure having you with us, and we hope to see you in future as well with us.
Actually, I was thinking for more discussions. That's what I planned the session for 45 minutes. But anyhow, that's good. Thank you very much.
Thank you, sir. Thank you so much.